I'm Dr. Aaron Franke from the University of Florida and University of Florida Health Cancer Center, where I serve as a thoracic oncologist and the co-director of the Thoracic Disease Site Group. So I think more importantly than just the outcomes we look at as oncologists is obviously how is this going to affect patient care and how is it going to better their quality of life and survival. And showing them acronyms for things like EFS and PCR aren't really meaningful to them. So in a recent conversation I had with a patient about this new data, she has very good lung function, a good surgical candidate. She does have a single station N2 node. So I gave her the recent data, and the way I explained it is, with your molecular profile, high PD-L1, with your stage of cancer, there are high rates of recurrence regardless of when we give the chemo, before or after. But for patients who get upfront immune therapy with their chemotherapy, and we find that they have a complete pathologic response, they are then not, as of what we know now, slated to get an additional 4 months of chemo, followed by another year of immune therapy that we actually have no data to show that is even beneficial at that point. So 3 cycles, aka 12 weeks of treatment to mitigate, 16 months afterwards, I think is something that, one, is sounds appealing to patients. And I also described that the truth is the delivery compliance, being able to tolerate it and decreasing complications in almost every tumor type has been shown to be easier to give before surgery than after I cut out a lung and a patient has to recover. So these ideas of keeping patient-centric endpoints in mind is crucial to help designing the most effective trials, but the ones that patients are going to want to go after, not just because of a pathologic endpoint.